I hope everyone's still awake. That's about as much Afrikaans as I'm going to speak this afternoon. As Adrian says, I'm from Oxford. I don't think he pays my salary. If he does, he should be reported, because it's really not very much, Adrian. So I'm here this afternoon. We've heard from a couple of people who really are international pioneers and leading experts in this field. And I guess I'm here as part of the next generation to tell you that there are educational paradigms out there which are going to lead us towards POCUS. So the guys who've spoken this afternoon invented this for us, and the opportunity is there for us to go out and learn how to do it properly and apply it to daily clinical practice, which is certainly what I do. I think I'm not going to try and give you a full review of the topic this afternoon. It's something personal to me, so I'm going to tell you the pathway I've followed to get here. And during the chat, I'm going to visit one or two articles which do look at consensus statements relating to education in point-of-care ultrasound. So it's me and the remote. I don't have any financial disclosures, but going into this talk, I must tell you that I'm very biased. I'm a complete disciple of point-of-care ultrasound, and it has revolutionized the way I practice medicine. And I'm sure each and every one of you, as soon as you start using this more and more, you'll agree with me. We have this picture which Adrian showed this morning, and I first saw it in a talk Adrian gave, and I think it really speaks to the fact that the ultrasound is going to be a vital clinical tool looking down the line, and it shouldn't be something to be ignored anymore. So that's me. That's where my point-of-care ultrasound course started. That's Bloemfontein in South Africa, 750 mijl van Kaapstad. So everyone who meets me always asks, how far are you from Cape Town? So there's more to South Africa than Cape Town, and this is where my training started. So that is the Universitas Academic Hospital. It's the smallest teaching hospital in South Africa, but it does offer the full range of specialist services. And as an anesthetic trainee, the first sort of hands-on experience I got with ultrasound was essentially regional anesthesia. Now, the difference between how I learned it in South Africa compared to how many European counterparts may learn regional anesthesia was very much a fact of a professor telling me, this is an interesting case, let's try quadratus lumborum block tomorrow. And then I went home on the internet, and Google and YouTube taught me how to do a quadratus lumborum block. So really quite self-taught in that respect, and also for vascular access. And then I was fortunate enough to attend a FATE course. So Professor Erik Sloth from Aarhus in Sweden, I think, came up with this FATE paradigm, which is focused assessment transthoracic echo. And this was basically a course which follows the remit that many point-of-care ultrasound courses today do follow. And that involved a bit of pre-course teaching, which was done online. And you finished a pre-course test based on what you'd learned online. And you needed to pass that to show some sort of theoretical understanding of ultrasound, very basic, so that you could understand what you were going to do. And then there was a one-day full hands-on sort of exposure course led by local faculty from Bloemfontein and Professor Sloth himself. So this was the first time that I'd sort of seen the whole spectrum of online learning, doing a bit of reading at home to sort of get yourself familiar with ultrasound terminology, depth, focus, gain, and all that. And then have experts show you how to get images, how to interpret images. And after that single day of teaching, you were said to be FATE positive, and you could leave and you could go and FATE all the patients you wanted to. And I started using that quite routinely as an anesthetic trainee. As you can see, South Africa famed for terrible weather. And that's why I then left and moved here. Clearly moved to Oxford for the weather, look at that. I think that's the one sunny day a year we do have. None of these, by the way, are anything to do with the hospital. The hospital is not as beautiful as this. The hospital is a hideous white building on the hill, and we never show that in our slides. We try to keep that concealed. But moving to Oxford, I was exposed to sort of, I think, a more modern idea of teaching, which has its own problems, and I think I'll get to them one step at a time. So as Adrian said, I'm a fellow in Oxford, so I do full-time clinical ICU work, and then I have protected time in my daily or in my weekly routine, which I do point-of-care ultrasound with, and that's divided into 3-month blocks of basically everything we've spoken about today, so cardiac, pleural, abdominal, and vascular access. And it's quite nice because it does go out of the basic remit. It still stays true to the philosophy of being point-of-care, but it gives you a bit of a bigger armamentarium to call back on as a clinician. The structure to it is really quite nice, and I think if we trying to train up more experts internationally. What we've done in Oxford, or what Adrian and his predecessors have done in Oxford, is really quite a good template of potential fellowships like this. So we are expected to complete the CUSIC module. Again, involves a bit of online learning. You have to show that you understand a bit of the theory of ultrasound, and then following on from that, you attend a course such as this one, and then from that, you need to do a certain amount of supervised scans for each of the modalities you are training in, and after that, you'll do a triggered assessment where a local mentor supervisor says you're good enough to do pleural ultrasound to an intensive care physician level. We also do FICE, which is the Focused Intensive Care Echo, which is similar to what you're learning today. And again, follows a similar routine of theoretical testing, hands-on experience, and triggered assessment at the end. And this all happens within the auspices of the Intensive Care Society. So the Intensive Care Society in the UK has been quite proactive, I think, in putting CUSIC and FICE out there. It's interesting to note that there's a strong drive to make both of these mandatory if you want to register as a specialist in intensive care in the UK. But we can't do that yet because not enough people have access to the level of training we're expecting. And whether that's a problem and whether that's prohibiting more people from getting into point of care ultrasound needs to be spoken about. Nonetheless, the guidelines are there, and there's a pretty rigid and pretty straightforward pathway as to how to reach your accreditation with the Intensive Care Society. So all this is not thumb-sucked. Well, I suppose we could say it was a bit thumb-sucked, but it was thumb-sucked by experts. So this is the, and then it's fine, right? As long as it's a bunch of experts getting together saying, we don't know, but let's try this, then we all agree. And this document was published in 2010, I believe, after a expert roundtable discussion on ultrasound in Vienna. Two things about this document. It still forms the basis of a lot of point-of-care ultrasound teaching, and certainly national guidelines that followed on from this, of which the UK is just one example, have referred back to this document quite heavily. The second thing I want us to notice about this document is the amount of times expert is used in the title. And that's not to be frowned at, that's to agree as a group of people that ultrasound in critical care is a pioneering field, and we don't have data, and we should probably not be waiting around for data that it changes outcome, and it's intuitive that it's going to change outcome. And a group of highly respected intensive care physicians from around the world, you can see it's endorsed by a number of national bodies, they agreed on this document. And I think we shouldn't, just because of the fact that they can't rate level 1 evidence, we shouldn't miss its importance. They referred to this as a basic departure point, so they expect intensive care physicians to be able to do basic echo. And there are a number of documents that have come out, particularly from the European Society of Intensive Care Medicine, that cite basic echo as vital in assessing the shocked patient. So most people would agree that an intensive care physician, or at least going into the future, most of us should be able to do that. But also that there should be general ultrasound skills, such as abdominal and pleural, which we'll talk about this afternoon. And this document also outlines the basic training pathway, which I've touched on a bit, and it says there should be a theoretical base. So I urge you, if you came here today on this course and you didn't do any theoretical reading, it's useful to do it. It's useful to be able to understand the speak of ultrasound and to understand depth, focus, gain, and the rest of it. And as you become more advanced, that really does become quite essential. Following on from the theoretical base, there should be supervised studies. Now, they're not very clear who should supervise this. Should it be nationally appointed experts? Should it be people at a local level who've shown an interest in point-of-care ultrasound? So they leave that a bit open to interpretation, and I think rightly so. And then you should keep a logbook of a certain amount of unsupervised scans. So you'll do for cardiac stuff in the UK, for instance, you do 10 supervised scans, and you need to follow that on with 40 unsupervised scans. You need to provide logbook evidence, and each of these cases needs to be reviewed by a mentor or supervisor. So it is quite cumbersome, and it takes up a bit of time, but there is expert consensus that this is what's needed. And then there's always an element of testing and assessment. Again, the document doesn't outline how that should be done. In the UK, that follows the form of sort of a triggered assessment. So you will do a case, and your local expert or supervisor will say whether your level of competency is acceptable as an intensive care physician. And then one we always like to forget is, sorry, let's go back to that slide. So one we always like to forget is the quality assurance bit. So if you're going to be serious about doing point-of-care ultrasound, you should regularly look back on your own practice. And you should ask yourself whether what you're doing is adequate, whether it's professional, and whether the level of imaging your trainees in a unit are delivering, whether it lives up to certain expectations. So the quality assurance bit is quite important, and one we always skip out on. So, no offense to any Canadians in the audience, this is not a particularly special document. I use it as a reference or as an example of a number of international, or a number of bodies around the world that have come up with similar documents. This is just a recent one. And this document is important because it refers back to Vienna, or the Vienna document, but it adds in a couple of interesting differences. And I think that speaks of the way our understanding of point-of-care ultrasound teaching is starting to evolve. They very clearly state that the training should be done by local experts. So there's no local national body overseeing training. A unit will decide Dr. X is good at cardiac ultrasound. He will be our local expert. He'll come up with a program within what they suggest, but he'll decide whether you've met competencies or not. So that takes some of the governance issues away from it. They squarely recognize that there's no adequate way to assess someone's ultrasound skills, and that the best way to do this is to be taught ultrasound by a person who can then later show or can comment on the fact whether you've improved and whether you've incremented your skill up to a level that you can be seen as a specialist colleague in the field. And it's interesting to note, if you're going to follow a numbers-based training protocol, they use about half the numbers required when compared to the British system. So some may say that we are too keen on having unsupervised cases and racking up the numbers in the UK, and that has been a problem for some people who struggle to finish their POCUS training. And then it acknowledges the issues that numbers-based training has, but what the document doesn't do, it doesn't come up with a pleasant alternative. So we still don't have anything better. And then again, core skills are outlined. So that's the sort of basic umbrella term within point-of-care ultrasound. We need to define, for our trainees' benefit as well as for those of us who are teaching point-of-care ultrasound, we need to say what our minimal expected skill set is. And that needs to be as simple and basic as it possibly can. And then after that, anything you add on should be, first of all, you should be very careful about building things outside your core skill set into patient care, but it shouldn't be expected as a standard. And then the Royal College of Radiologists in England were quite scathing of these types of documents, and they've been quite scathing in terms of what we've come up with a point-of-care ultrasound training platform in the UK specifically with. But I think they've done it in good faith. I genuinely think, as a group of colleagues, they're trying to give us some sort of steering guidance as physicians as to how to deal with an imaging, teaching and imaging protocol. This specific comment was the scathing comment I referred to, and they say lots of our training programs are reasonable, but many of them are not. I want to be slightly controversial, and I want to say that if we as clinicians at the bedside are learning to do basic ultrasound skills, our whole philosophy of getting the image differs slightly from the philosophy you should have as a radiology trainee, where eventually you will become a specialist who comments and gives expert consultant level feedback back on really complex imaging studies, whereas point-of-care ultrasound should never be that. So I do wonder whether radiologists are the right people to direct point-of-care ultrasound teaching, and I'll leave it at that. So in the UK, I've mentioned briefly that we are running into the problem where a lot of trainees in intensive care medicine attend these sorts of courses, and they keep saying to us they'd really love to finish their training in point-of-care ultrasound, but they can't finish their training. So reasons they can't finish the training range from not having local experts available, not having enough time to finish the recommended amount of scans. But at the end of the day, we've got people who are hungry to learn the skill, and somehow through putting really well thought through training schemes out there, we may actually be prohibiting a certain amount of people coming through and finishing their training in time. So the SMART paradigm of education or of enforcing new ideas is quite a useful one to go about. We need to be specific about what we want from our trainees. So we need to outline the core skills expected, and we need to stick to that. Not over POCUS. So the minute POCUS becomes very complex, it goes right outside the philosophy of what point-of-care ultrasound should be, and that's dangerous to training first and foremost. And well, first and foremost, it's dangerous to our patients, but it's also dangerous to training. It needs to be measurable. That's difficult in point-of-care ultrasound training but we need to be able to see a measurable improvement in the way patients are being scanned by our trainees, and the only way to do that is to have a dedicated local faculty. We need to be realistic, and what we set out as goals have to be attainable. And then finally, we need to have some sort of time. We can't give you 10 years to complete point of care ultrasound accreditation, because what you've learned in year 1, you would almost certainly have forgotten by year 10. So we need to be quite hard on that. I think in the UK, and this might be true for other parts of the world, the attainable bit has proven difficult. And this probably falls back on the numbers-based method of assessment. And we need to start asking ourselves whether this is really necessary and whether we can come up with more useful alternatives or more achievable alternatives. Part of the problem has been finding a local mentor to review your scans, and colleagues from Warwick in England have come up with this sort of website. So this is, I quite like this, and this is UK based. Unfortunately, it wouldn't be available to you in this country. But it's something to think about as trainers going on, as to how to circumnavigate this problem of not having enough local expertise in terms of training. So the Hocus-Pocus platform is basically an online viewing system. So you do your scans, you anonymize patient data, and you upload it onto this website. Your mentor can be sitting 1,000 kilometers away, and he'll review your scan. He'll send you an email back saying you did this right, you did that wrong, please do another scan showing your improvement. So it's sort of remote mentoring, which is helping guys in the UK specifically overcome this problem of not having attainable training at their hands. And I like it because it uses technology, and it takes a real problem and it comes up with a reasonable suggestion. Then finally, we need to talk about quality assurance. Just make sure I stay under time. So quality assurance is important. I'm not going to say too much about it. It definitely is the elephant in the room. And it relies on these basic premises. And within the point of care ultrasound teaching paradigm, this is repeatedly mentioned. And it's one we often forget about, conveniently. But we need to be recording our scans. We need to be reporting them at some level so that a senior ultrasonographer can come along and he can look at your reporting and your recording and say, these two are congruent, you're safe, the way you're impacting patient management is fine. And then it allows more expert review at a supervisor level. Of the imaging quality and in terms of audit process is very important. So this specific paper, which comes out of Oxford, is really nice in terms of outlining how an imaging protocol within an intensive care unit should audit their regular practice, and is worth a read. The next slide is unpublished data from Oxford, and it will stay unpublished because we're very embarrassed about it. But we've recently done an audit, and we are one of the units in the UK that really does a lot of point of care ultrasound on the ICU. And we'd like to think of ourselves as leaders in a certain sense, but we're only reporting 40% of our focused intensive care echoes. That's of the echoes that were saved. There are numbers of echoes that get done that aren't even saved onto the system. So whoever wants to come back and look at the quality of the echoes can't do that because the images aren't there. The level of reporting we can't even comment on because the numbers we generated after a full year's audit was just too low. We couldn't generate enough data to say that we are reporting accurately. So that's a big problem. So don't expect that in any journal. We're very embarrassed about that. And other than Adrian, don't tell any of my bosses I've showed it to you in Antwerp. So then I think a nice parallel is often drawn between the stethoscope and this ultrasound machine, or the point of care ultrasound machine. And it's good, but it's also useful to run through how we were taught to use a stethoscope. So how many of you as medical students had to complete a logbook of 50 auscultations of mitral regurgitation? We basically got given the stethoscope and we said, go forth and auscultate to your heart's content. And we were making pretty bizarre diagnoses sometimes, which the consultant cardiologist would come and lay his finger on the pulse and he'd say, you're wrong. But basically, the teaching around using a clinical tool has been there for centuries. There's nothing new. And it's always going to follow theoretical learning, which we're doing in ultrasound. And it's up to us to go out and read up about it. So a large part of learning to use the stethoscope was us being responsible clinicians and learning to realize the difference between a pansystolic and a crescendo murmur, because it was important for patient care. So a large part of point of care ultrasound is being responsible about what you're learning and improving your skill. So we're doing good with theoretical learning. Supervised studies we're doing, and that's great. I'm not going to take anything away from that. I think it still is one of the most important tools for teaching this important clinical skill. We have differing opinions about the logbook, and certainly none of us use the logbook to learn how to use the stethoscope. we should have an assessment of competency. Someone should tell you you are safe to go and do basic echoes. And we have to be better about getting quality assurance programs rolled out. If POCUS or point-of-care ultrasound as a specialist modality wants to be taken seriously. And then finally, last slide, I think take-home message from today, we hear the word expert thrown around quite a lot in the ultrasound literature, but it's true, we need more experts. So all of us should go out today, upskill ourselves, and wherever you work, endeavor to become a local expert. Beware of over-focusing. I'd like that to be my slogan for this course. Don't try and diagnose grade 3 hydronephrosis with cholesterol-containing gallstones from a point-of-care ultrasound. It's not possible. And it detracts from answering simple questions and directing therapy at the patient bedside. But if you're doing POCUS within that philosophy, answering a specific question within an achievable amount of time, please do go and POCUS everyone. I think I've not said much about it today, but we need to be having this discussion about whether undergraduates should be exposed to point-of-care ultrasound. I think many of us would be very different on this course today if someone at medical school had shown us how to. So I know in South Africa at the University of Cape Town, you can't qualify as a doctor unless you've finished a basic echo course. That's standard now. Quality assurance, we're doing badly and we need to do better. And then there's lots of room for education research. We need to be talking about how to better educate ourselves. Guys, and that's me. I think point-of-care ultrasound is amazing. I'm happy to answer any questions. And if you have anything, so our hospital isn't really a horrible white building. It is actually quite slick, or bits of it are. And if any of you have questions or would like to talk to me about the fellowship, I think it's a great way to roll point-of-care ultrasound out. And I've left my email address up there for you guys as well. I thank you for your time. Dankie.